Hello, good evening everyone, and welcome to the eUROGEN webinar programme. I'd just like to take a couple of minutes right at the beginning to inform you about what a European reference network is. They're quite new developments created by the European Commission in 2017. And EUROGEN is one of 24 which cover different medical fields, and they're all dealing with patients with rare diseases or complex conditions which require highly specialised healthcare. So the aim for us as a network is to try and deliver quicker specialist advice so that we can get a high quality diagnosis, treatment and care for those patients with rare urorectogenital conditions who need highly specialised surgery. So some of the things we do in the network is all the highly specialised healthcare providers and their clinicians are collaborating, and we can do virtual consultations using an IT tool provided by the European Commission called the Clinical Patient Management System. And this allows us to conduct, if you like, a virtual European level MDT, so that we can provide expert advice to any healthcare professional who requests it across the EU. We're also active in training and education, so along with this webinar, we're also launching an exchange programme to try and encourage young trainees who might be interested in specialising even further in the rare and complex, so we can arrange visits between our different healthcare providers so that they can see and learn some of these rare and complex cases. We're also working together on guidelines in the future, clinical guidelines and other clinical decision support making tools, and we're also building a registry, which is a very exciting development at the moment. So next year we hope to be 60 healthcare providers, and we hope that all our clinicians will be actively including their cases in the registry. So we hope quite quickly we'll have a really rich source of data, real-time clinical data from which we can do research. So that's what we're all about, and this evening I'm really delighted to introduce, we have 3 speakers today. We have just bear with me a moment, I'm just moving my screen along. We have Caterina Grano, who is Associate Professor of Clinical Health Psychology at the Department of Psychology, Sapienza University, Rome. She's a member of the ARMNet consortium, who obviously has been collaborating with EUROGEN since the beginning. She conducts field research in the field of quality of life and well-being in patients born with anorectal malformations, and she's published several papers on quality of life in patients born with ARMS. We also have Chris Verhaak, who's Associate Professor and Clinical Psychologist in Pediatric Psychology, and also Aukje Aerts, Health Psychologist working in clinical care with children with ARMS and Hirschsprung disease and their families. And they both work at Radboud Amelia Children's Hospital in the Netherlands. And that's, of course, a centre of expertise for patients and children with ARMS. So without further ado, I'll hand over to Caterina. I very much hope you all enjoy the webinar, and thank you for joining us this evening.
Okay, now yes, I think now you can hear me, I suppose.
Yes, that's right, Caterina, thank you, yes.
Perfect. Just a second, I try to iconize this thing that, okay, just a second. Okay, so good afternoon, everybody. Thank you, Michelle, for the nice presentation, and thank you, Darren, for your kind support. I wish also to thank Professor Weitz and Ivo de Blau for this invitation, and thank you everybody for participating to this seminar. I'm going to give an overview of the research on quality of life I've been doing in the last 10 days together with the Italian Parents and Patients Organization for Anorectal Malformation. There will be a section for question at the end of our seminar, so please save the question for later. First, how quality of life is measured. Quality of life is a multidimensional construct which reflects an individual wellness across several domains of life. Also, the measurement has to include at least 3 domains, namely physical, emotional, and social functioning. There are 2 types of measure. Disease-specific measure have the advantages of focusing on specific issues of immediate relevance to the patients with a particular disease, for example, evaluating the impact of fecal incontinence on the physical and social functioning of the patient, but preclude the comparison of quality of life among patients with diverse diseases, since are constructed to be specific for that disease. Conversely, generic measures of quality of life assess aspects of health and well-being independently from the specific disease, making it possible to directly compare quality of life among different groups of patients, and also comparing them with healthy peers or normative data. One of the most used another distinction we have to do is between self-reported measure, which are aspects, measures evaluated directly from the patient by the patient, or proxy-reported measure, which are filled in by generally by the parents, and are used especially when the children are too young to fill in the questionnaires alone. One of the most used disease-specific questionnaire in the ERN is the disease-specific quality of life questionnaire developed by Henneman and colleagues to be used with ERN patients and Hirschsprung disease. And it has been translated in several languages. There's a French version, an English version, and I think also a Spanish version. And it encompasses 10 dimensions like laxative diet, constipated diet, fecal continence, social functioning, emotional functioning, and body image, and other areas, but has some limits in that some of these subscales are constitute only of a couple of items. So the reliabilities of this scale sometimes is in some subscale is quite low. We validate the Italian version of the questionnaire, which is slightly different from the original one, since we changed the response scales to a 5-point format just to have better distributions with the better distribution with the data. And we use this questionnaire to compare quality of life in among adults and children. And what we found that adult scores worse in the emotional, in the body image, and in the physical symptoms area. So they feel more ashamed and embarrassed about their condition compared to younger people. They feel less attractive and more dissatisfied about their body, and they report more physical symptoms such as abdominal pain and bowel movements. But at this point, our question was if this difference were ascribed to different cohorts of patients. Children may have, for example, benefit from the recent advances in surgical techniques, while adults did not, or if quality of life in patients with ERN decreased as children became adults. So this was our question. To start answering this question, we followed children along a period of 6 years, and we asked children to fill in the HQL questionnaire when they had a mean age of 6 years old, and after this period, when they became older, when they had a mean age of 12 years, so while they were entering the pre-adolescent and adolescent developmental stages. And what we found was that the quality of life enhanced a long time in the areas of presence of diarrhea and fecal continence, while again it went decrease in the social functioning, emotional functioning, and body image areas. One can argue that the lower score for of adolescents in the psychosocial areas of quality of life may simply reflect a normative change in development. It is a critical period for all adolescents, therefore physical and psychological change of the body, as well as more normative comparisons. So I think maybe you will not know an adolescent who has no problems in the area of body image and emotional functioning. So our next question has been, is there a difference among the quality of life of adolescents with ERN and healthy controls in quality of life? And we conduct another study in which we compare 109 children with ARM with 336 controls, using this time a generic measure of quality of life to be able to compare the two groups. And we use the pediatric quality of life inventory, which is a well-validated and widely used questionnaire on quality of life, which include 4 areas that are physical functioning, for example, participating in sports activity or exercise, emotional functioning, for example, feeling afraid or scared, school functioning, for example, paying attention in class or missing school because of not feeling well, and we analyzed the difference between the two groups, and we didn't find any difference in the patient and in the when we compare the patient group and the healthy group as a whole. This is in line with other studies. For example, 9 colleagues found similar results comparing Hirschsprung disease patients, ARM patients, and controls using the same measure of the pediatric quality of life inventory, and also they found the same results with another measure of general well-being, although Hirschsprung disease patients scores a bit lower. This is a study from the group of Ivo de Blau, and also they found that cloacal malformation patients report similar quality of life as female patients with less complex anorectal malformation. So it seems that quality of life in some way is not directly related to the severity of the disease. It's not there's not so a direct relationship. However, when we went to see more in detail the data, we found that there was an interaction group per age. In particular, we found that in a group of children, in our data, in the group of children, you can see in orange are they are the patient group, and in green the healthy group. We can see that in the children group there is a difference with children in the ARM group scoring lower compared to the healthy group, while this difference becomes not significant in the adolescent group. Also, we can notice that there is an increase in a quality of life in the patient group as they enter adolescence, while there's a decrease in a quality of life in the group of healthy children when they grow. In which areas children of the two groups differ? They don't differ in the physical domain. They only differ again in the emotional, social, and school domain. While in the adolescents we did not find any difference, it is not correct to draw conclusions from a not significant result, but Hartman also didn't find any difference, and she said that adolescents with ARM may have learned over time to cope with their chronic physical health problems, thus improving psychosocial competence in coping skills. So differences that emerged when these patients were children are no longer present when they became adolescents. What happens in adults? What happens in adults? As we can see in this slide, we can see that we compare adults using the SF-36, and we can see in violet the ERN group and in green the normative data from the SF-36 manual, and we can see that there's a significant difference in physical functioning and bodily pain in that ERN patients scores better than the normative population, while they score lower in the role physical, in the general health, in the social function, and in the role emotional. And again, the social functioning is the area where the difference with the normative data is higher. So can we do, so our next question was, can we do something to enhance quality of life with in the patients with ERM? According to the 11th Health Regulation Model, health-related quality of life is not directly influenced by the illness itself, so by severity of the disease or symptoms, but it can also significantly influenced by it can be also significantly influenced by illness perception and social resource like coping styles or social support or self-efficacy. So in line with this idea, we think it's important to identify the personal and social resources, because if we identify these resources, we can change these resources, and so we can change also the perception of quality of life. Esther Arman did a lot of research on conduct different studies analyzing psychosocial aspects that affect quality of life in our patients, both in children and adolescents and in adult patients. And she focused especially on self-esteem, mastery, and social support. And she arrived to this conclusion. It appears that psychosocial function has the most important effect on quality of life of patients with ARM or Ishmael disease, while fecal incontinence and constipation have almost no effect on their quality of life. So in line with this research, we evaluated the role of some psychosocial variables, especially self-efficacy, which is a very well-known construct in psychology research. It is defined as the person's confidence in performing a particular behavior and in overcoming barriers to that behavior. So it is concerned not with the confidence in performing the behavior. It is not concerned with the skills one has with that behavior, but with the judgments and one has about whatever he or she will be able to do the behavior. And we know from other diseases that patients with greater self-efficacy has been shown to practice more self-management behaviors, leading to better disease control and better physical function, and finally also better quality of life. So in line with this research, we developed a self-efficacy scale for ARM patients. We developed one also for the parents, which I will not present here. An example of items from this scale: how capable do you feel to be able to, for example, overcome embarrassment with other people, friends, colleagues, schoolmates due to your health problems, or keep yourself up to date with regard to information about malformation. And we were interested in analyzing whether self-efficacy could mediate the relationship between fecal incontinence and quality of life. We introduced the self-efficacy in this equation, and we saw that actually self-efficacy, the effect of fecal incontinence on quality of life turned to be not significant when we introduce self-efficacy in the equation. That is, change in self-efficacy determine a different path of fecal incontinence on quality of life. We do not have time to focus here on other psychosocial resources that may be improved, but we analyze also the role of coping style strategies, which are the ways in which we afford the situation and which typically afford a problem. For example, trying to solve it, This would be a problem-focused strategies and active coping, or trying to reappraise the situation. This would be an emotional focus strategy. Or finally, using maladaptive coping strategies like denial or substance abuse or self-blaming. And we found that once fecal continence was considered in the impact on mental health, also maladaptive coping strategies negatively predict mental health. So higher scores in maladaptive coping were related to worse scores in mental health, so higher mental health. We also analyzed the social support of the mothers, and we see that mothers who perceive more social support experience that fecal incontinence has a lower impact on quality of life of their children. And more recently, we focus on positivity, which is quite a new construct in psychology. Positivity is a general tendency to view, interpret, and evaluate positively various life domains, including oneself, one's future, and past experience. It's a basic disposition. And we found that actually positivity could partially mediate the relationship between fecal continence and both physical and mental health. So how can we translate these research findings into practice? These data have clinical relevance since, for example, self-efficacy may be taught and changed, and thus low self-efficacy may be also increased. So self-efficacy can be promoted by four aspects, which are mastering, modeling, persuasion, and physiological states. Considering mastery, it is important to give the patient the opportunity to actively participate in the task, for example, in the bowel management, thereby providing hands-on interaction with the task. For example, the EMR organized an outpatient clinic run by nurses, by Elena Scarpellin, where the parents had and by Angela, where the parents had the opportunity to learn how an enema is done and how to manage the stoma and the problems associated with these problems, and how to perform, for example, catheterization. Clinician can help patients experience mastering by guiding them to set goals and develop action plans in which they experience success. Give patients, for example, tasks of moderate challenge, that is, tasks that they can succeed with moderate effort. With no much effort. And for example, you can create a list of tasks and start with the most manageable. In the IMR, we give the opportunity to kids to experience ways to manage their disease out of the family, and doing experience in autonomy far from the family's developmental tasks that patients with ARM may reach afterwards compared to their peers, due to the fear of fecal incontinence episodes or due to embarrassment. And so it's particularly important to give these opportunities to do this type of experience in a safe environment. So, for example, the association organized holidays abroad to learn English, and Angela, who is a specialized nurse who works with the IMR, has led this group, I think, in England. And also, the association, these are small groups of with pre-adolescents and adolescents, and they are working in this case on body image. And but also the association has have published some books on how to afford the malformation and explaining malformation to small kids. But also setting achievable goals with the patients and the parents, speaking in a realistic way with them, giving information of what the patient of what the patient can reach and what the patient cannot reach. There's also the IMR implements also a free dedicated telephone line where the where patients can call for asking about doubts and asking suggestions. Considering modeling, patients' association are eligible settings since people have the possibility to share the same experience with other people who have already go through that experience, so they can learn from other participants. We know, for example, that the greatest increase in self-efficacy are when the model occurs, when the model are similar to the observer. So introducing a patient with ARM to another patient who have successful self-managed experience, or to mothers speaking of their children, this is really a very important intervention. And finally, physiological state, explaining the bodies, how the bodies responds. For example, what happened when I eat an ice cream, or I know that my body reacts when when I will eat pasta, but I cannot eat carrots, or how I feel after a bowel management, or how I feel when I skip it, how I recognize that I feel well. This is a guide for small kids written by the Colorectal Center for Children of Cincinnati, where the children were asked, and that has been translated with permission by the IMAR, and children are asked to think about what happened to their body, for example, when they eat, what they can frequently eat and what they not, and for example, they are asked to draw what they can eat and what they can't eat, or the part that food do in their body when they eat something, and they are asked, for example, to draw their poo in the different ways they know, or to draw the poo of their friends. There are other physiological reactions where we can work for awareness, like heart rate, arousal or activation, breathing or breathing, and also psychosocial support, psychological support. This is Silvia Bucci, who is a psychologist that who have worked with the IMAR in the past, and with her we set sessions of a group of 4 sessions for the parents, where they have the possibility to recognize and express their own emotion, where they know emotional regulation, where there was a session about school, parents, friends, the importance of social support and social network, and ways to afford the disease. So guided by the model, the social cognitive model that we use to work and to do also the research part. Finally, there's also the possibility for patients to take part in psychotherapy session with a specialized psychotherapist, or in individual sections. To conclude, I want to show you 2 reviews, 2 very recent reviews. One is from 2020, and the other one I just come into it this morning because an alert comes in my mail that they were citing me, and so I saw it this morning. But I'm happy that there is more attention now on the psychosocial factors affecting quality of life of patients with ARN and Hirschsprung disease, because I think this is a really important aspect. And in one of these meta-analyses, the author conclude that to improve health-related quality of life, patients as well as their parents shall be encouraged to enhance their self-awareness of the disease and learn coping strategies. So there are also other areas which we didn't go through in this seminar, but it was already so much things. So, for example, sexual functioning, or depression and anxiety, and symptoms of depression and anxiety, or post-traumatic stress disorder. But these are also important issues to be studied. And finally, just to conclude, I prepare a little test to see if you have been paying attention. It's a quiz competition. The fastest who answer will win, and you can answer with this QR code with your camera, with the camera of your phone, or you can go to menti.com and digit 91446657. And I think the best thing is to check who is the winner afterwards in the in the question session. So thank you very much for your attention.
Thank you very much, Darren. Michelle, thank you for the introduction. And Caterina, thank you for the great presentation. I'm Verhaak, and he is my colleague Aukje Aerts. And we will explain you something about our work in the multidisciplinary team in the Amalia Children's Hospital, where we work with children with anorectal malformations. So clinical management with children with ARM, psychological perspective, and we will focus on young children. And it's important to realize that anorectal malformations interferes with normal development of the child and later the adolescent. And in every developmental phase, the disease will play another role. And I think Caterina already explained it, that the quality of life in adolescents changed, and also in adolescents with ARM, and that could also be part of the specific developmental phase adolescents are in. And on the other hand, the development of the child interferes with anorectal malformation and its outcomes too. So going to school asks for specific abilities regarding continence, and not only for the child, but also for the parents. Toddlers are developing their autonomy, learning to control the defecation, and it's so important for clinicians to be aware that every phase needs a new treatment perspective and also a new treatment plan. And in this presentation, we will focus on two critical periods for the young child. The first is the postnatal period, and the second is the period around toilet or potty training. So first, the first period for the little child, just after birth. So what's important for this little baby? It is to establish a basic security in relation to caregivers. That's established by experience, responsive parenting, so caregivers reacting to signs of the child's discomfort. And it's not difficult to imagine that getting a child born with ARM interferes with being responsive as a parent. The birth of a child with ARM is a traumatic event for many parents. Immediately, there are concerns regarding health. The parents have to hand over control of their newborn baby, something that totally interferes with their own needs to just help and take care of their baby. They have to let their child undergo invasive treatments, and they also have to learn to be responsive for their sick child. And all this takes place in a period that other parents can enjoy their maternity or paternity period and can recover from childbirth. And that this is potentially traumatic is reflected in the high percentage of post-traumatic stress disorders in parents of a child with a serious medical condition. It is about 20% of the parents suffer from post-traumatic stress disorder complaints. And these quotes reflect perfectly where parents go through. When you have a child born with ARM, it's hard to admit that you have no control. All you can do is to trust the doctors in the hospital and to support your child as much as possible. Everything else is out of your hands, and it takes time to accept that. That's very hard because you think, I'm the parent and it's my job to take care and to fix everything. And so you see here in this slide several efforts, several tasks parents have to deal with in confrontation with the birth of a child with ARM. There's a difference between acute and post-traumatic stress disorders. Acute traumatic stress disorder is quite common and you can identify it by feelings of numbness, intrusive memories and thoughts, avoidance regarding the specific problems, negative mood and strong emotions. And mostly acute traumatic stress disorder symptoms disappear after some weeks. But if they continue to be there, then we speak of a post-traumatic stress disorder if symptoms continue even after 1 month. And what's important, and is already what Caterina also indicated, that there is a limited relationship between the seriousness of a medical condition and the emotional response, also related to the risk of trauma. So one take-home message regarding trauma in relation to ARM, and what we learned from research data also, is that objective indicators of the illness of the ARM or the injury severity are not good predictors of which patients and family members will go on to have lasting traumatic stress reactions. And this means that it's not only the most ill or the most severely affected child who may need extra attention. So therefore, it is very important for clinicians to, in every parent, address risk factors for post-traumatic stress disorders. And what can health professionals do? Health professionals can take care on different aspects. The D of distress, to take care of the distress of the child and the family. So assess and manage pain and other discomfort and ask for fears and worries, the parents. Also provide emotional support. So who and what does the child and the family need now at this moment? And are there any barriers to mobilize the existing supports? And then more specifically to the whole family, coach family stressors and resources and check resilience for this specific family. And assess the distress in the family and also address other needs beyond the medical. So not only medical needs, but also psychological, social and spiritual needs. And we will explain this a little bit by a story of Laura and her parents.
Yeah, so I'll tell about Laura and her parents and what we did in the hospital to help them. So a little introduction. Laura is the first child from a single mom, and the mom broke up with Laura's father during pregnancy. He has no part in their lives. So after a relatively carefree pregnancy, Laura was born after fast delivery. It was a great joy, but when they wanted to take her temperature, they discovered there was no ANS and happiness changed in fear. Laura was immediately taken to another hospital, separated from her mother, and had no close family member to go with her in the ambulance. So Laura's mom experienced great stress and guilt because she couldn't be with Laura. The next day, there were a lot of unexpected medical researches and invasive treatments. So on top of the funeral first days of becoming a mom, physically and emotionally, mom had to deal with a lot of information and unexpected events and loss of control. And this made her feel very insecure and guilty, and she had no idea how to be a mom. And also there was no postnatal care to help her out. So the nurses in the hospital, they did the best they could, but because of all the researches and treatments of Laura, this was underexposed. So after 5 days, mom's collapsed and she had to take complete bed rest again. And again, she experienced loss of control and not being able to take care of her child. Okay, so what could we as healthcare professionals do? Well, we stayed with the distress first. So we try to reduce the distress. So we assess management and manage pain and other discomfort for the child. And you can make it explicit for mom or the parents. So mom knew that Laura's pain was being seen and managed. But also you can take care of the needs of the mother, assess pain and discomfort for the mother. So ask her about it and monitor her physical well-being and help her recover in stressful situations. For example, make sure there's help with flask, or make sure mom is able to sit comfortably with her child after just giving birth. And also make sure that she gets enough sleep. And it's very important to actively ask mom or parents about their worries and fear and what they need. So you need to listen, explain, and comfort parents and help them to be, sometimes help them to be in the now and not to worry too much about the future. Give confirmation to everything they do well, normalize feelings as a normal person in an abnormal situation. And we give give psychoeducation about what she's experiencing and how this is normal and what they can expect in the near future. So that's what we do about distress in this case. And now, what can you do about emotional support? So the big question is, who and what does the child and parents need now? So for Laura's mom, it meant she needed her mom to join in the hospital for mental support, despite the COVID rules. And she needed consultation in the hospital from a psychologist for mental support. And there was a child life specialist for the child, so for Laura, to cuddle and rock Laura while her mother was sleeping, and to arrange some extra attention. For example, giving a dream blanket. It's a special blanket kids can get. And also we encouraged mom to comfort Laura and let her know she did well, and to talk and sing to Laura as she would do at home. And there were no barriers to mobilize existing support except from COVID maybe. But for Laura's mom, there were no barriers, so we did well, but there won't be a social worker if she had needed help. So then the last one is to remember the family. So look at family stressors and the resources, and check resilience, assess distress in family, and address other needs beyond medical. So we made sure mom took care of herself and explained to her why we thought that was important. And we made sure we involved family. So so also mom's brother was giving support to mom, and she didn't have to be alone. And they would help her out in shifts when she got home with Laura. And Laura was the firstborn in this family, but make sure that you think about brothers and sisters also. What can they do and what do they need? So, for example, we let them take pictures. So they know, they can see the baby, they know it's taken good care of and it's doing well. And we also make sure that there's a good balance between mom being in the hospital, or mom and dad being in the hospital, and also being able to take care of the brothers and the sisters. And it's important to give attention to the translation of out of hospital care to the situation at home. So it's not it's not too big of a change. And in this case, we arranged home care. So a last thing which I find very important is to keep paying attention on the distress, on the emotional support, and on the remember the family every time the patients visit the hospital. And make sure you pay extra attention when the child and parents have to start dilatation. In Laura's case, we made sure that there was home care, that the nurse specialist took extra time to explain and prepare mom and grandma. And extra attention was given to help mom see how she could comfort Laura. And what I always do, and I think is very helpful for parents and important, is that I address the ambivalence between the need to dilatation in order to keep your child alive, but how it conflicts with every parent's dedication to keep their child safe and comfortable. And if you can explain that and feel with the parents how hard that is, that I think is very helpful. So in conclusion, we saw great distress where mom had no time to recover, had great concerns about her child, and felt loss of control and feelings of guilt. The aim was to reduce stress, give back feelings of control and self-efficacy, and enhance social support, seeking environmental resources, and we were attentive in our approach. So we kept in contact with mom in the time between the different admissions to the hospital, and especially when they were admitted in the hospital. So they're doing relatively fine at this moment.
So it was an example how we supported care to prevent post-traumatic stress disorders in a mother at risk. And now we go to another period, very critical for children with anorectal malformation, the toddler and child from 2 to 6 years with anorectal malformation. And it is about toilet training. How are we doing toilet training, and how do we decide on how to start and when to start? And also how to balance the medical needs of the child and the psychosocial condition. And also how to come from the intention to start the continence training to the actual continence behavior. And I will explain that from a protocol that is based on research we did in our hospital, and we still carry out this protocol in our daily practice. And the studies are published from Van Kuik et al. And what's important is that there are different steps from knowing what you have to do and why you have to do specific bowel management, to continue to persist specific behavior. And there are several steps that are important, and these steps you can relate that also to self-efficacy, that all these steps support self-efficacy regarding continence. And it starts with knowing why. It is important first that both the child and also the parents know why it is important to have a regular schedule for continence training, and that's how for the child important to know how the food is, how the pathway is from the food in the mouth to the poop that's coming out of the body. And the child must understand that there are processes in the body that must be stimulated. And also the parents must understand that the child needs help to come to a good bowel management. And the next step is daring. Daring is very important. So many children with anorectal malformations has some anxiety regarding pooping and regarding everything related to their anus. So pooping is something that is emotionally burdened. And therefore, it is important to address these aspects and to be sure that the child will not be in pain, and also to be careful for parents that they can dare to also not to focus too much on a clean child, but to focus on little steps that have to be made for the child to reach or probably not reach continence. And the next step after daring, so as daring is solved and the parents and the child aren't anxious regarding the next step, then wanting is important. Is the child willing to follow the instructions for continence, for bowel management and for continence training? And also, are the parents in a good situation to have time and to have a good schedule at home to support this bowel management? And after that, if we were sure that this is the best period and everybody is ready to start, then it is important that they are also able to. And for the child, it's very important that there is good technique in bowel muscle, the use of the muscles necessary for the continence. And therefore, we collaborate with a physical therapist very closely, who investigate the child also to support good muscle movements. And when we are sure that the child is also be able to follow good instructions, then the next step is actually doing. And actually doing is related to just plan when the bowel managements take place, when the child goes on a potty or to the toilet, and how you can schedule that the best into the daily schedule of the whole family. And that's also important to consider. And if child and parents can do this, then the next important step is also to persist in doing it. And that's what you could remember yourself probably, that you can change your behavior, but it's sometimes much more difficult to persist. And also important to prepare parents that also in the next step, that persisting is also in other efforts. And we in our hospital also support parents by follow-up visits to support also persisting behavior. So, and we will now illustrate this protocol by the story of Brenda of 6 years and her parents.
Yeah, because Brenda is the oldest child in the family with no additional problems, and she has one younger brother. And in the background, there are fertility problems and miscarriages and prenatal diagnosis, which caused great concerns during pregnancy. And after birth, there was harm, and mother experienced comparable distress as Laura's mom had. So being overwhelmed, feeling insecure and loss of control, and not having postnatal care. So Brenda needed several surgeries which were without complication, and this enhanced parents in their parenthood and self-efficacy and feeling able to take care of Brenda. So Brenda developed well as a toddler, and there were no worries, and she was spontaneously potty trained by the parents, and she was well integrated at school. But at the age of 4, when she was being potty trained for 6 months, of continence for 6 months, there was a relapse because of a severe renal pelvic inflammation. And this caused great distress by parents. The mother was scared of Brenda not being potty trained again, and she was very indulgent to Brenda. And father thought Brenda was fooling them, and he wanted her to be potty trained and disapproved when Brenda was wearing diapers, and he was very strict in disapproving little accidents, like a wipe of poo in her diaper. So we talked to the parents, and we decided, we as the psychologist and the physiotherapist, because it's a very important, how do you say, collaboration. We need each other very much. So we talked to the parents, and there were good conditions. So we started the training, and the first step is knowing. And I will take, I will let you in on what we did with Brenda. So for Brenda and her parents in this phase of knowing, we explained to Brenda according to her age what she had to do and why she had to do it. And she got insight of what she could do herself, and that made her gain a little self-esteem and autonomy. And she experienced great pleasure by learning about what happened to the food in her body and how it went from the mouth to the poo. And that was also a moment of joy between Brenda and her parents. And for her parents, the major emphasis in knowing was understanding why they should take small steps and why they should encourage autonomy. And also understanding that inability is something different than unwillingness. So the physical therapist could explain very well why the inflammatory caused the setback and why it was not the unwillingness, but unable to. And that made father look a little bit softer, I think, or a little bit more love to his daughter. So that was knowing, and then we could go to daring. And for Brenda, the aim was on helping her dare to poo again. And although she felt, she could feel when she had to poo, and she could poo in the toilet, she was persisting on wearing a diaper. So we encouraged her feeling when to poo and to poo on the toilet. And we were making no problem of the diaper, and we trusted there was a point that she would decide to let the diaper go, which also happened. But we helped her overcome her fear of accidents by reading books, using play techniques, model behavior from parents. And then when she was had enough self-esteem, the diaper went off, and she dared to poo without the diaper. But that took some time and some trust from parents and some patience. Now she's daring, and we're in wanting, and this was difficult because Brenda had high demands for herself, so she wanted it very much, a little bit too much. And if she had she set the aim high, but would also give up if she didn't make it. And the same for her parents. So where the father was also having high demands and the mother felt very responsible, so we took time to explain, going back to knowing, why it's important to take small steps and to have trust. So then they were able to do it. And in this phase, there were several relapses because of 2 different reasons. The first is a physical, because Brenda had several inflammations, which caused setback, but also psychological. She had problems switching attention, which made it hard for her to switch attention to her bodily sensation when she was playing, but also to get actively go to the toilet. So when she was playing, she had a little bit more accidents, and we had to take care of the attention switching. So again, it took time, and it was an effort in patience. So in this phase, her parents had to learn to focus on being continent and learn to accept failures, and thereby setting a model for Brenda and also giving her the courage to become continent and again also dare. And then the next step was doing, and Brenda learned to exercise on fixed moments. So she learned what she had to do and how to do it, how many times to squeeze, how to squeeze, but also on fixed moments. So we helped parents, but it helped her when her parents explained. And also we trained her to think about pooping herself. If it helped to do it at fixed moments, for example, before breakfast, before playtime at school, and after dinner. And for parents, the focus was on supporting Brenda to structure her training, but also to structure their lives. For example, they had to go home after a dinner with friends. They couldn't stay because Brenda had to do her exercises in time. Otherwise, she would get an accident. So they had to structure their lives, but also let her do it herself and accept that she was gaining autonomy and make her own decisions. So sometimes she wouldn't do the exercise and she had an accident, but that way she got the motivation herself. So then she was doing fine, and now we're in the persisting phase. And in this phase, we kept explaining why it's important for her to go to the toilet at fixed time. Also, she thought, well, I can do it, but that's true, but she needs the fixed times to not have so many accidents. And we helped her lower the bar so she keeps motivated and learns to accept her own little mistakes or little accidents. And parents need to be reminded to keep patience and confident, and also to be encouraging. So after a relapse, which she has sometimes, they can trust that it's a little step back, but she will do 2 steps forward. And that's because there is maybe a problem in being able to after an inflammatory, but the knowing and the wanting and the doing is still there. So although the training has stopped, this family can always keep in contact with when they experience difficulties, and we try to encourage them to get back to what they know, what they dare, what they need, and so on. And especially mom is calling sometimes for a little bit of support.
Okay, and then after these 2 examples, we finish with here the statement that children and family differs in their resilience to deal with this invasive chronic disease and its treatments, and they also differ in their needs for additional care. And what's important to realize is what makes families more vulnerable and what makes a family need some additional care. And what already is indicated in the webinar of Barbara Lacobelli and June Rogers on bowel management is that bowel management could only have positive results in children with specific anorectal malformations. And in others it is very difficult to realize. So of course that aspect of the illness and treatment is important, and also from psychological perspective, if the illness is life-threatening and long hospitalization and the invasive treatment and unexpected conditions makes that families are more at risk to need some additional support. But also characteristics of the family. Also in situations where you think, oh, the anorectal malformation is quite straightforward. But if there's a lack of resources, socioeconomically, for instance, or if there are other health problems in the family, mental or physical health problems, if there is a lack of social support, or if there are other stressful life events in the family, for instance, financial problems or just moving to another place or something like that. And also beliefs are important, very important to address. So earlier experiences regarding illness and treatment, and also the experience of a lack of control and helplessness. So these factors are also important to take into account to screen also what families need some additional support. So the take-home message from our presentation is first to be aware of trauma So trauma not only around childbirth, but also trauma that could be re-experienced by other problems during the life course of the child and the parents. And think about reduce the stress, handle emotions, and take care of the family. And know that doing is more than knowing, and differentiate between knowing, daring, being able to, wanting, doing, and persisting as all important steps in getting some control about the continence. And also be aware of risk for coping problems, risk related to the illness, to the child, and to the family. So thank you very much for your attention, and thanks also to our team. I give the floor back to Darren. Yes.
Yes, thank you, Chris, and thank you, Aukje. So yeah, I think the first, Caterina, I don't know if you can bring yourself back on if you want to maybe go through your results. In the meantime, we've got a few questions that come through for Chris and Aukje, so I'll send them on to you now, so you should hopefully see them. Just give me 1 second. You there, Caterina? Great, I can unmute you as well, hopefully.
Okay.
Great, yep.
I think I will give you again the QR code, because I think only few people have answer. I don't know if someone else wants to answer.
So okay, I can make you the presenter again if you want, Caterina, so you can show it again.
Okay.
So yeah, if anyone else, just while we're doing that, has anybody else got any questions, please send them in now. If you can indicate maybe which presenter they're for, that would be great as well. So yes, a QR code again. So if people want to do that, you can be doing that while we answer some questions.
Meanwhile, there are questions you can answer.
Yeah, so I sent a few on to, have you seen them, Chris, the questions? I think you're on, we can't hear you at the moment, so.
Yes.
Ah, great, okay.
Okay, so you want us to answer the question?
Yeah, if you want to go through them, if you, that's okay. Yeah.
So there's one question, and it's from Dalia Amino, and she asked, what happens to the family when they go home? Do they get psychological support still from the hospital? And yes, they are. So if it's when a child is born, we always catequinted. I don't know if I say it right, but I go to the parents, and we meet, and I do the things I told you. And then if there's a problem, or if there are the mother has severe emotional problems, I always call, and I always keep, not only if there's severe problems, I always keep in touch. And sometimes I call the doctor,
family physician.
Oh yeah, family physician, and we arrange for a mother to get psychological help in her neighborhood. But also sometimes it's enough to have a conversation or a consultation once a month or once in the 6 weeks. But if there's needed more, we will arrange it through the family physician. So, and there's another question. Did Chris and Aukje meet parents who were not able to carry on with the dilatation because of too hard pain caused by it? I'm not working that long by the REM, but I have met a lot of parents who say it when they look back. They say, "Oh, I don't know how I've done it," and who experience great pain or great psychological pain afterwards. And therefore, for for me personally, I know it's very important to talk about the dilatation and to talk about the ambivalence, about what I told. You need to do it to take care of your child, to keep it alive, but at the same time, you need comfort. So we try to seek a balance, and the home care can take over if needful. But I also speak to parents who had no problems at all. So yeah, I focus on the comfort they can give their child and how they are great parents, although they couldn't do it, or they did it and they have guilt. So I hope that's enough of an answer.
And last question: what would you recommend? What would be your recommendations in terms of timing for toilet training in ARM children? Yeah, I don't think that you can give a fixed answer to that. But what is in general important is that the decision on the good timing, I think, is a multidisciplinary one, and you have to not only focus on the medical, the somatic condition, but also on the physical, on the perspective of the physical therapist, and also on the perspective of the psychologist. And you have to make the decision in a multidisciplinary team, so that you from all the perspectives could decide on what's the best timing for the toilet training.
Yeah, and if I can add, sometimes there are social problems. So the child may be ready for the toilet training, but the social problems may be so big, or like divorced parents, if they're just divorced and the communication is not well enough, then you can do this, because they need to be able to talk about it. They need to be able to. So then the child can be ready, but social support isn't enough. So you have to look at all those different phases.
Okay.
Okay, I can't see questions. I don't.
I think that's. No, I don't think we have any other questions. So
one. I can see the answers if you want, Darren. If you...
Go, Caterina. That's good. Yes, if you want to go through them.
So you will invite me to present the...
Yes, go ahead. Yeah. So people can see the screen, your screen. So.
Can you see the screen already?
Yes, yeah.
Oh, okay, perfect. So compared to health adults, in which quality of life areas do adults born with ARM report worse quality of life? In the psychosocial area. And which are the advantages of generic quality of life measure? It was A plus B. They can be used to compare patients groups with healthy peers, and with in quality of life, and can be used to compare quality of life in patients with different diseases, but not seizure. They can be used to evaluate specific quality of life areas, because the specific areas related to the disease are only of that disease. So in the normal population are not. It's not possible to measure, like fecal, like some specific symptoms, for example, diarrhea and etc. And which of the following are mediators of the fecal incontinence quality of life relation? I think this was not did not appear to you. The only answer is mine, and it's not self-efficacy, but it's all previous one are correct. So social support, self-efficacy, coping styles, and positivity are all mediators of the fecal incontinence quality of life relation. So there's no leaderboard. Okay.
Thank you, Caterina. Okay, thank you all. So thank you, first of all, greatly to the presenters today, Caterina, Chris, and Aukje. Thank you very much for doing that. Thank you all for attending as well, to those who are still with us. I would say just quickly, please, we've been recording the webinar, so if anyone had any problems or missed any of it, we'll be making it available tomorrow, hopefully. It'll be on our YouTube channel, and also I will be sending a link to that and to the one on the GoToWebinar platform as well, if you can't access it on YouTube. Please also check out our website for future webinars that are upcoming. We have lot more coming up on anal rectal malformations in the next few months. We're doing 1 a month webinars on that topic, as well as others as well. So check out our website to see those. If anybody has any other follow-up questions afterwards, then please send them in and we'll try to do our best to get an answer for you. I should say to the presenters, we've had a few coming through. I haven't sent you, they're not questions, but saying thank you for the excellent presentation. So again, thank you very much to you for doing that. Yeah, with that, I think we'll say goodbye. So thank you very much again. And hopefully those who attended will see you all soon as well. Thank you.
Thank you, Darren.
Thank you for the attention.
Okay, goodbye.
Bye.
Bye-bye.
Bye-bye.